Good evening, everyone. It's August 16th, and I'm glad to have you join us on this week's virtual town hall, Living with Lupus and COVID-19 in Our Community. As always, I want to thank our supporters and sponsors. First and foremost, the Lupus Foundation of America, Georgia chapter, and Terry and all that she does at the chapter. We thank you so much for your support. And the Georgia Council for Lupus Education and Awareness with Representative Kim Schofield and Chris Reed and others. And then the GOAL Project, Georgians Organized Against Lupus, supported by the CDC, run out of Emory University in Grady. Well, worldwide, we have hit over 21 million cases and nearly 750,000 deaths, and the US has nearly 5.5 million cases and over 170,000 deaths. Brazil is number 2 and India number 3. And if you add up US, Brazil, and India, this is actually about half of the total number of cases globally. Just shows you how disproportionate the top 3 are. And we happen to lead all of that. I thought I'd show the map side by side this week, and you can see these are the hot spots throughout the world. On the left last week, and on the right this past week. You can see it's essentially unchanged, really, with it still being really red hot in the US and South America. And in the US, you see here the week before last on the left, and this past week on the right, in terms of hotspots in the US. 3 states have about over 500,000 cases. And these are California, Florida, and Texas. And Georgia is number 5 in total cases, so we're not that far behind. And if you look at it in terms of total cases per million population, we're number 7. So cases continue to surge throughout much of the US, particularly in states that were among the first to reopen. We have 8 states that have an increase in number of cases this past week. 21 have been stable, and 25 have some decrease in cases. This is 2 weeks prior compared to last week, and across the US. On the top, you have new reported cases per day over time, and you can see how the initial peak never really went fully down, and then we have an increased second peak, or continuation of the first peak, as I think most people would rather look at it. And you see the cases coming down 2 weeks prior, but this past week it seems to have plateaued a bit. It's good that it's not going up, but as in the case of everything with COVID, you just can't relax. And then in terms of deaths, you see a very large rise in the beginning, coming down, and then going back up. And it seems to have been coming down a couple weeks ago, and that curve is sort of flattened out. So we're not out of the woods by any means. I'm glad that things are not continuing in the high trajectory, but how much further can it go higher, actually, if you want to think about it that way? And it's not that good that things are not going down as much as we want. But some things to be happy about, some things to be continued to be concerned about. So this past week on a national level, just some things in the news. The US government is going to buy 100 million doses of vaccine from Moderna, and that they're one of several different companies that are in the late stages of vaccine development. And I think the US has gotten a deal with others like AstraZeneca. But the US is buying just from this one company alone at a price of about $15 a dose. And you're supposed to get, I think, 2 doses or so, about $30. 62% of US adults are very concerned about the COVID outbreak, and this is the highest level since late April. It's not good to have too much concern, but it's perhaps good that people remain concerned and not falling too far behind in terms of their protective actions, hopefully, that are connected with this concern. Many of you have heard about Russia approving a vaccine, and it's without undergoing full phase 3 trials. And there's a lot of skepticism and concern in other countries, but really tells you about the nature of the geopolitical and financial impact of developing a vaccine, and the upsides in being the first to have an effective vaccine. But really, what Russia has out there is it's probably going to go to some of their other countries that they're friends with, but you don't see many others in the quote unquote developed countries being very enthusiastic about it. As we all know, schools are reopening, and we're starting to see some outbreaks, and we'll talk about that a little bit. And some college athletics conferences are canceling fall sports because of some breakouts and concerns. This just came out recently. There's a FDA issued an emergency use authorization for saliva test. And this test, called Saliva Direct, does not require any special type of swab or collection device. Just a sample of your spit can be collected in a sterile container. And this process, or this test, is unique because it doesn't require a separate step where they have to extract the nucleic acid. So it's just a lot more complexity, but not only that. This is significant because the extraction kits used for this step in other tests have been prone to shortages in the past. And so being able to perform a test without these kits enhances the capacity for increased testing while reducing the strain on available resources. The exact validation method and the numbers, how good it is, in other words, it seems from what I'm hearing early on that it's reasonable. It's not going to be as accurate completely as the swabs that you get up the nose, but what we call the PCR tests. However, having a test that is certainly much more adaptable, I think, to people's liking in terms of how it's done, and especially if it does not strain available resources, which that is the main issue that's limiting the spread of tests and being able to get the results back quickly. And that's what we need most of all. And so even if this test isn't as good or have the numbers of accuracy, if it's reasonably within close to what we have now in terms of the PCR swabs or the nasal swabs, I think this is going to be a huge step forward. Now, how quickly this gets disseminated out and into the public and all of that, I don't know, but it's a good step that they're announcing this. This is the week before last in terms of Georgia hotspots compared to on the right this past week. And it looks, again, fairly similar. But what I'll continue to point out is that all of Georgia continues to be very hot in terms of new cases, as we all know. But you can see that most of the really hot areas are outside the metropolitan Atlanta area. So there continues to be widespread active infections, particularly in the rural areas of Georgia. And that's what we need to continue to watch and be careful about. So this points out the really high impact counties for new cases in terms of cases per 100,000, and not too many changes, but there are some ones that are changing a little bit, but you can get a sense of those counties that are most involved. And then this is 2 weeks ago on the left compared to this past week on the right. And then on the top row are new reported cases in Georgia over time per day. And you can again see a mirror of the general US, that with the initial peak, it just never went down and it really went up recently. And then 2 weeks ago, or actually last week, I mentioned that it looked like it was starting to come down, and it continues to come down this week. So that's a good sign. In Georgia, the deaths, you can see here what I reported last week. And then you can see on the right here what the extension to include this past week. So again, like the US, the deaths are still very high, and there's not a clear signal that that's come down. So total cases are starting to eke down a little bit, still extremely high. Deaths continue to be very high. It's the take-home message both nationally and here in Georgia. In terms of hospitalizations, you can see kind of the graph here on the right. This is generally the suspected and the actual test positive cases that are in the hospitals in Georgia. And you can see a general trend that it's slowly starting to come down. Again, still very high in terms of numbers. And to further underscore that point, the lowest number of COVID-19 hospitalizations occurred in June 7th with 743. And this past Thursday, we have over 3,000. So we continue to have very large numbers. The hospital capacity in terms of ICU in general, beds in the state and regionally are not yet at full capacity, which is good, but they still continue to hover in that very delicate range where it won't take much to go from 87 to 99 and 100. So again, the theme is promising numbers in general, but we shouldn't rest on our laurels, and it could really turn on a dime. So in the news, regionally anyway, in this past week, we have the White House task force, Corona task force, again, continuing to strongly recommend that Georgia and a few other states adopt a statewide mask mandate based on the parameters of various numbers that we've looked at in the past. Georgia continues to be one of 16 states without some form of statewide mandate, meaning all the other states have some form of statewide mandate. Kemp said he continues to believe that a requirement is unnecessary and unenforceable. I guess in a sense, it's good that he withdrew his lawsuit challenging the city of Atlanta's mask mandate and coronavirus restrictions, ending potential resource and time-consuming legal dispute between the governor and Atlanta Mayor Keisha Lance Bottoms. So it basically does, in a way, allow Georgia cities to be able to keep their mask mandates in place for now, at least without a legal challenge from the state, which is good. We all heard about it's hit the national news for sure, about Cherokee County in particular, and there's pictures of a lot of these kids walking around without masks, or most of these kids, in very close quarters. And, we expected breakouts of COVID in schools. I mean, that was going to be expected. But when you open up a school in the setting of large numbers of community cases, I mean, what else do you expect? Especially on top of that, you have schools that don't put into place a state, or have the ability to put into place a mandate for masks. And when you have most of the kids not wearing it, I mean, this is absolutely no surprise based on how the virus works. There's a lot of it around. The kids are close together. They're efficient in transmitting the virus, and boom, you have over 1,000 kids that are quarantined. And just today, a third Cherokee County high school announced plans to temporarily end in-person learning after 500 students were quarantined after having 25 tested positive. So is this a successful school reopening? I mean, we're learning a lot, that's for sure. And hopefully people will continue to remain healthy past the infection and all that, and there won't be too much impact on the learning. We need to keep them all in our prayers. I thought I would share just kind of when I'm searching in the scientific literature of what's been published. There's a government search engine called Pubmed. It's run by the National Academy of Sciences, or the library arm of the government, basically. And so it captures really the big peer-reviewed publications throughout the world. And so this is in a journal called Annals for Rheumatic Diseases. It's the journal that comes out of the European version of the American College of Rheumatology, called European Alliance League Against Rheumatism, European League Against Rheumatism, EULAR. Anyway, it's a very, I think it's probably the highest ranked journal in the rheumatology field. So it's certainly very impactful. And this is an article from Malaysia that highlights that people with lupus that were hospitalized, the hospitalization rate for lupus declined during the COVID-19 pandemic in the early phase. But those that were hospitalized sort of after that early period had much more severe symptoms needing intensive treatment. So active disease of lupus and infection remain the main causes for hospitalization in people with lupus during the early part of the pandemic. And so the pattern of hospitalization among patients with lupus was consistent with some other studies that have been reported as well, where disease flare and infection contributed as the main reason for hospitalization. So their data and my impression of what I'm seeing personally in the patients that we serve suggests that people with lupus have avoided coming to the hospital. And on one hand, that makes sense. Early on, it was very confusing and scary. And you have an autoimmune disease and you're taking immunosuppressive medications and you don't want to risk yourself, and everybody's being quarantined or being told to stay at home. But unfortunately, what we're seeing are a lot of people who, as a result of that, have not been able to refill their medications, not following up and taking care of things earlier when the flare is a bit more manageable. And we're starting to see a lot of sick people with not COVID, but with really severe lupus flares. So I bring that up to underscore the importance, obviously, of maintaining your health. And we have to put all of this in balance. And I know it's a tough call sometimes, but and I know there are situations that make it more challenging to go to see a doctor. But I just want to continue to urge everyone to be very mindful that lupus doesn't stop because of COVID, obviously. So going to our questions. So here's a group here who's considered to be in close contact with someone who tests positive for COVID-19. Basically, I think, when do you need to worry when you find out somebody that you're physically close to has COVID-19? And close contact with someone who's COVID-19 positive really depends on the protective measures that we've been talking about for weeks and weeks and weeks. So if you had a known contact with someone who later, shortly later, was diagnosed with COVID-19, you need to think back on what type of interaction you had. Did you maintain social distancing? Were you able to consistently stay at least 6 feet away? Were both parties wearing masks throughout the encounter? Were you able to clean your hands and the surfaces during or after the interaction, and certainly before you touched your face or anything like that? And these things can sometimes be modified too, depending on the circumstances. Such, for instance, you may be greater than 6 feet away But if you are in a very confined space with poor air circulation, or you have an air conditioner that blew from the infected person towards you, I mean, 6 feet really is kind of a general distance, but you have to keep those things in mind. So again, if all the protective measures are being maintained, or you thought they were maintained or pretty comfortable, then you would still monitor for symptoms, but you should be more assured, obviously, that you were protected. But if you continue to be around other high-risk individuals and you're concerned about transmitting the virus, I don't think you have as high of a risk. But again, you just want to be more careful. You should consider testing, and always watching out for symptoms. Now, if any or all of the protective measures were not maintained, then you need to quarantine yourself. Quarantine means you don't know if you're infected, but you may be, and so you want to protect other people. So you remove yourself from interacting with other people. Isolation technically means you're known to be infected and you're removing yourself from other people so that you don't infect them. So you want to quarantine yourself until one of two things occurs. Either 2 weeks passes, which is really the period of time that most people will develop symptoms and be infectious, or you have a negative test, whichever occurs first. And I would definitely try to get a test done during that period of time, because that would be the best way to know for sure. And I hear it's taking still like 3, 4, 5 days for test results to come back. But it's certainly better than 2 weeks. And if you're not having symptoms and you have a good test that's done and it's negative, then I think you would be more confident going out. Now, the incubation period for COVID-19, which I haven't heard of anything about the coronavirus. I think you're referring to the White House task force changing the incubation time, but the science continues to show, to my knowledge, that the incubation period, which is the time between exposure to the virus, in other words, becoming infected, and then symptom onset. So the time you get infected with the virus to the time that you first show symptoms is the incubation period. And the average is about 5 to 6 days. However, it can be up to 14 days, which is why we generally recommend, if you're going to quarantine yourself, you weren't protecting yourself, you've been around somebody who's known to be COVID-19 positive, until you get a negative test back, you need to stay out of circulation for 14 days. Or if you're definitely positive, you need to be out of circulation for 14 days. What are the age ranges for viral spread in children and adolescents? Is there one particular age range that spreads it more than others? It seems like more kids are testing positive. Well, as I mentioned earlier, there's no question that kids are getting more COVID, and to a certain extent, we expected that. But what absolutely doesn't make sense, focusing on the kids in schools, I guess we have to do that. But that's just a reflection of what's happening in the community. And that's why it's so frustrating for me to hear some of these stories, is that, yeah, we can talk about all these cases that are happening in the schools, but we expected that. And that's because we're not getting our act together in the community. So if we had been able to implement some measures earlier and did it more uniformly as a country, we would have had lower community spread, and therefore the schools would have reflected that. There would have been some pop-ups of infections here and there, but it wouldn't be to the extent that we're seeing it now. So yes, we're definitely seeing more. In terms of the question about one age range or versus another being more infectious, there was a study out of South Korea which may offer some insight into this. And they found that children younger than 10 years old transmit the COVID-19 virus to others much less often than adults do, but the risk is not zero. And those between the ages of 10 and 19 can spread the virus at least as well as adults do. So these findings suggest that as schools reopen, there may be some slightly different risk in terms of transmission. But again, they're not zero in either case. And it certainly explains why there are going to be big breakouts. And I think this is the last question. Can you explain contact tracing? Sure. Well, contact tracing is it's the key. I mean, this is right out of the CDC website that you can see at the bottom here. It's the key to slowing the spread of COVID-19 and protecting you and your family and the community. It's simply trying to cut off the virus going from one person to another. That's how the virus lives. The virus can't live. Viruses, by definition, cannot survive outside of a host. So they depend on being able to go from one fresh body to another. And it uses the engine of the body to then replicate and then infect other people. I mean, it's ingenious how it's created, right? It's a respiratory virus too, and it gets it all in the air. And so we mingle and we're social beings. And so it's simply, once you find somebody who's positive, letting people know that they may have been exposed to this individual that's known to be positive, and letting them know that they should monitor their health for signs and symptoms of COVID-19. And part of the process also is to help people who may have been exposed to COVID-19 because they interacted with an individual that's known to be positive, helping them to get tested, and asking people to self-isolate if they have COVID-19, or quarantine if they were in close contact until they know for sure that they're not positive, or 2 weeks passes, whichever occurs first. And so there are individuals that go out and try to do this on behalf of the government. When there's somebody that's known to be positive, they ask that individual questions and try to link back to people who they've been in touch with during the time that they were infectious. Now, before I talk about what that entails, what contact tracing does not entail are individuals asking for money, social security numbers, bank account information, salary information, credit card numbers. So in other words, they don't ask for sensitive information other than what is required to identify individuals, because that's obviously the basic essence of contact tracing. You have to be able to identify someone and to be able to contact them. So the principles of investigating and contact tracing is that public health staff workers will work with a patient or a person who's been confirmed to be positive for COVID, and help them recall everyone with whom they've had close contact during the time frame that they might have been infectious. And so then the public health staff then began contact tracing, if you will, by warning these exposed individuals or the contacts of their potential exposures as rapidly and sensitively as possible. And to protect patient privacy, contacts are only informed that they may have been exposed to a patient with an infection. They are not told the identity of the person who may have exposed them. The contacts are provided with education, information, and support to understand their risk and what they should do to separate themselves from others who are not exposed, monitor for illness, and the possibility that they could spread the infection to others, even if they don't feel ill yet, if they were to be infected. So they're encouraged to stay at home, maintain social distance from others, and monitor themselves for symptoms. And to the extent possible, it depends on the state and the jurisdiction, but there are some public health staff who then follow up and make sure that people are okay during this period of time. and then I'd mentioned a few weeks ago that the experience in New York and other states showed that contact tracing is an important part of stemming the flow of the virus. I hope you can kind of sense that. I mean, what's the point of testing if you aren't able to use that information outside that individual who's been potentially infecting people for the past 2 weeks? So this helps. It works. It makes absolute sense. It's an important part of getting the numbers down, but it is not easy. And especially in communities where there's a distrust of the government, which is something that I think we all need to be sensitive about. Even in an extraordinary time as COVID, to have a governmental agency or person querying about where you've been and who you were with, and you can imagine, especially in the undocumented population, but especially in other minority populations too, it's a point of sensitivity. So the numbers are very poor. It still needs to go up, but just the unique aspects of the communities that we live in our history, in our country, I think it's a complex question, certainly in my mind, of how to do that more effectively. But we need to keep trying. And I hope for those of you who may have the opportunity to do this, if you're willing or don't have some of those issues, you would participate in this. Okay, that's it. Thank you again for another week, and thanks for your questions. Please continue to visit the lupusga.org website and the COVID resource, along with all the other amazing resources that Terry and others at the LFA Georgia office collate together for us each and every week before, during, and well after the pandemic. And keep sending us your questions by 3 p.m. of the Sundays that we continue to have these, and give us an idea of how we can better serve you. So thanks again, everyone. I appreciate your time. Have a great week and be safe. And wear that mask.